regional anesthesia, because and subsequently 80s and 90s, by doing number of regionals, and when they have compared the data with the past 3 years, from 50s to 60s, they found out that regional anesthesia is 17 times more safer than general anesthetic, especially in pregnant patients. And anything less than 90% of regional anesthesia incidence in an obstetric setup is considered to be suboptimal services, anesthetic services. So the regionals, in fact, the best of obstetric centers, the obstetric regionals constitute about 98% of all anesthetic services in pregnant patient for undergoing various obstetric and non-obstetric procedures in pregnant patient. And subsequently, it was the 90s saw redefining of various standards were redefining, and basically all to improve the maternal and the fetal safety. So much so that the year 2007-2008 was declared as the International Year for the Study of Pain, for the real pain. The importance of a study in this year was notably the labor pain was considered to be a good model for studying acute pain, the pharmacology, the assessment of the validation of acute pain in a pregnant patient, because these are the women where the medications which need to be given, which are safe during pregnancy, and if anything can be given during pregnancy or in a pregnant woman, is safe for non-pregnant women as well. So subsequently, in the same year, Jose Carvalho is considered to be the father of obstetric ultrasound, and he said regional anesthesia in obstetric is going to stay for long, and we just need to step up refine the technique so as to minimize the adverse effect and take it to the zenith, so as to maximize the success. Several things came later on. The measuring tools, there are several ways to measure the pain relief in labor. There are 103 or 104 methods, but still the gold standard is the Megill's pain questionnaire. Of late, there have been new techniques, CO2 laser-based systems have developed, which assesses the VAS score of the patient, and these are going to be the more easily available validating tools for pain in the years to come by. The major boost to the regional anesthesia and obstetric happened in the last decade because of the technological advances, and you have heard enough of technological advances this morning, the availability of ultrasound, the newer techniques. Newer drugs and adjuvants are now available, better drug delivery systems, especially the availability of computer-integrated pumps for maintenance of analgesia, both intraoperative during labor and postoperative analgesia, newer drug regimes, newer insights, newer concepts. The controversies have been redefined, and there are several controversies have been buried altogether, especially those which led to the sessions like does epidural cause backache, does epidural cause increased cesarean section rate, so on and so forth. And of course, there have been several exciting research that have happened to minimize or to identify the complications of early identification of complications of secondary regional anesthesia. The newer drugs which have come in the market, especially the ropivacaine, bupivacaine, levobupivacaine, from my experience, levobupivacaine, of course, we have not used, but ropivacaine is no different from conventional bupivacaine. It's just that the cost is high, 7 times more than bupivacaine, and otherwise, it is just one more drug available in the armamentarium. But yes, availability of newer adjuvants like clonidine, neostigmine, exciting research has been going on. At the moment, there are no clear-cut consensus available. But down the lane, about a decade later, it's said that local anesthetic are going to become adjuvants, and these drugs are going to be the mainstay. So that it's going to be, the woman is going to be fully ambulant without any local anesthetics. The spinals in obstetrics have been redefined. The era of the low dose, the conventional dose of spinal, 15 milligrams of bupivacaine or 12 milligrams of bupivacaine, is no longer practiced, because we have now realized that it's not prevention of hypertension, but treating the hypertension aggressively. It has been studied extensively over the last 1 decade that after a conventional spinal, we have been using various vasopressors, mephedrine, ephedrine, and but there have been exciting research which says that phenylephrine is a better drug of choice for treating spinal hypertension, preventing spinal hypertension, because the cord pH is the one which, especially it indicates the long-term neurological outcome, especially in those babies who are extremely low birth weight babies or preterm babies, wherein even hypotension of 3 to 4 minutes can be deleterious in the neonatal outcome. So whenever you're giving a spinal anesthetic to a woman who is for preterm delivery or has a low birth weight baby or a IUGR, it is better to go or confine yourself to the low dose technique, and rather than treating hypertension, prevent hypertension by giving prophylactic phenylephrine, not ephedrine and not mephentrine. We have come a long way from Quink 20 gauge needles to 25 gauge Quinky tips, and now the present era, we no longer practice Quink. How many of you still use Quinky needles? I'm glad to see that there are only few hands. But the norm is to switch over to Whitaker needles, because whatever morbidity that is seen secondary to. How many use Whitaker needles? Okay, I see more hands. Rest of them are using both probably. Well, the present norm is do not use Quinky tip needles, switch over to Whitaker needles, because whatever morbidity you can reduce the PDPH, because it's almost about 7 to 10% with Quinky, and with Whitaker it is less than 2%. So you have availability of Whitaker needles. It's slightly expensive, but it is worth the cost because of the morbidity can be reduced. Epidural spinal needles also, there have been a lot of changes. Earlier we started off giving epidural spinal in different spaces. Then we had sequential needles to needle, and now you have sufficient needles of different lengths available to catering different types of patients. And even the catheters have been modified to suit individual patient needs. We have come a long way, wherein we had a single orifice open-ended catheters to blind tip lateral head catheters, beveled catheters. We have radio-opaque catheters. But remember that whenever you're using radio-opaque catheters for routine surgeries, in order to put a barium line or a lead line to make it visible during X-ray, you're reducing the tensile strength of the catheter by 40%. So routine cases, better not to use the radio-opaque catheter, go for conventional catheters. And generally, what we follow is the closed tube lateral head catheters, which are beveled orifices in the distal 1.5 centimeters of the tip of the catheter. We have now available the newer devices to fix the catheter to prevent catheter migrations, because it has been found out from our experience, as well as the literature says, that after 4 hours of lumbar epidural, 40% of the catheters migrate, and 40% of the catheters migrate out rather than migrating in. And you may have a patient with inadequate analgesia or suboptimal analgesia, or probably each time you have to give a top-up, the patient complains of pain because the catheter migrates in. And the best way to prevent migration is to use such devices, especially when you want accidental catheter removal because of shifting or ambulation. Because we do lots of epidurals in mothers who are on anticoagulants, and these mothers, we need to put the catheter at a particular interval and remove the catheter. Even the removal has to be a planned removal rather than unplanned removal, and it's better to use such devices. We discourage the use of tegaderm, because this was one of the favorite thing in early 2000s. The companies came in and they said, you can see the catheter tip and its visibility is good, but it's an occlusive dressing, and even a drop of blood is a good culture medium. And there have been few case reports in the literature where they have found out that the incidence of catheter-related sepsis, especially the central line sepsis, is more, and they have correlated the same thing with epidural catheters also. So tegaderm as such should be discouraged for epidurals. Enough has been talked about simulators. Dr. Vishali, Dr. Vas has discussed extensively in the morning, but these are also the things which can be used in pregnant women. One of the things that has available in the recent past is acoustic puncture assist devices. I have used this in a couple of cases, but this was a demo piece that was kept in the hospital. It's an excellent device which renders the ability of you holding the syringe when you're advancing or identifying the epidural space. It basically contains a cartridge filled with normal saline, and while you are inserting the epidural space, it gives the audio signal, and once you reach the epidural space or road resistance space, the pitch of the audio signal changes, and this is where you identify the space, and the accuracy is almost 99.9%, and they have found out that especially the beginners or the postgraduates who are trying to learn epidurals with this device, the learning curve is much shorter, and probably every postgraduate institute should have this device. Not very expensive, but it's a thing which is available in the market now. Ultrasound guided, of course, Dr. Gopal has mentioned quite a lot about this, but coming out from the annual description, this is also known as sawtooth appearance of the spine. especially pre-puncture ultrasound in patients like this where anatomy is not known. It is very useful. We are using, but we are not using real-time ultrasound. We just identify the depth of epidural space so that you know what length of the needle has to be used. The highest length so far we have used was 11.5 centimeters depth. And this was possible only by using neuroaxial tech. Otherwise, you would have failed. You wouldn't have reached the epidural space. It also helps in identifying or predicting grading of difficult spine score. We have introduced this scoring system in our hospital. We have validated in our hospital. We have not published this data, but it works very well where we grade the spine and we know that it's a grade 5, grade 4, or grade 3 spine, and it works. It's working good for us. Probably once we validate it nationally, then we can modify it and see that we can grade that. We can evaluate a difficult spine score also using ultrasound. Combined spinal epidural analgesia is also another exciting that has happened last decade. For the first time in 80s, Dr. Rao et al. Did 100 cases of CSE in a pregnant, for cesarean section and published the data. He was questioned like why 2 punctures, 2 needles, but subsequently now it has become a standard technique, and it's just a matter of time that it becomes a standard technique for labor epidural also. CSE was the first time was described in 1937, but 1990s the major boost happened because of the availability of sequential kits. Again, when one company introduced these kits, there are several other market-driven theories and papers that came into the market. And they said that probably when the spinal 29 gauge or 27 gauge Whittaker needle is introduced to the Huber point, there is a release of macrometallic particles into the subarachnoid space, which can cause probably, or which were identified under electron microscope, and they were attributed that it may cause some sort of transient neurological irritation or symptoms. And it was just one of the company came out with a back eye. And they found out that when the needle with a back eye, 80% of the time the needle can come through the back eye, but sometimes it comes through the Huber's point also. So to improve the efficacy of the needle to pass through the back eye, they came out with a needle with sheath. And this was all a market-driven research. And it was just a matter of time that one more anesthesiologist in the US patented a double lumen epidural needle where you have a channel, separate channel for spine needle and a separate channel for epidural catheter. The whole idea was, it was assumed that when you are creating a rent on the dura with a spinal needle and subsequently when you are threading the catheter to the same, there is a possibility that the catheter can go into the subarachnoid space with the dural rent created by 27 gauge Whittaker needle. But this controversy was put an end by Holstrom et al. Who is an Australian anesthesiologist who did a study in a cadaver. He dissected the dura of the cadaver. He created a rent of using 27 gauge with a Whittaker needle and tried to introduce 16 gauge and 18 gauge epidural catheter. And his conclusion was it was impossible to thread an 18 gauge and a 16 gauge epidural catheter through a rent created by 27 gauge Whittaker or 27, 25, 26 gauge Quincke tip needles, even if there is a multiple sieving. So all this double lumen needle with back eye, it is just a company-driven research, and they are misleading the clinicians of favoring one needle over other. And as a clinician, you need to know the things which best suits your working condition. No doubt that CSA offers better blocks, better analgesia, especially the sacral sparing, which can be sometimes be seen in second stage of labor. And especially if you are doing a procedure of labor in an advanced labor where the mother has low down pain, perineal pain, then CAC is a technique of choice because it has best and worst of all the worst. Worst because the incidence of meningitis is relatively more. It cannot be said for certain at this juncture of time, but it has been found out that the incidence of meningitis following a single short spinal is about 1 in 1 lakh. With a continuous lumbar epidural is 1 in 1 lakh to 1 in 1 lakh 20,000. But with CSC, it is 1 in 20,000. So till we reach equal number of CSCs as there have been spinals and epidurals, we cannot say with certain, but it has been proposed or hypothesized that because there is a rent on the dura and subsequently you're threading the catheter, there is a track, there is a transcutaneous migration of the bugs into the epidural space, and if there is a bloody tap or if there is a blood collection inside the epidural space, there might be increased incidence of meningitis. Especially Dressner et al. First time in 2006 reported a case